Thank you very much. Thank you very much to the organizers of this wonderful program, and thanks for inviting me here, and I'm happy to be able to give a talk today. And my talk is on why and how to optimize hemodynamics pre-implant. Talk about optimizing right heart, renal, and hepatic function with temporary support. This is a picture of our medical center. This is the famous Drexel Dragon. This is our medical school. This is the hospital that we use as our teaching hospital, which is Hahnemann, and another picture of the front of the medical school. Dr. Eisen and Dr. Lee did a wonderful job of reviewing a lot of why we need LVADs and when to consider LVADs. We heard a lot about patient selection, and we talked about the right ventricle and how to evaluate it pre and post. So what I want to focus on instead is a little bit really on the mechanical support. Mechanical support is super important because we want to select the right patients. If we put an LVAD in a patient who won't survive, then we're really wasting technology and healthcare resources. But there are some patients who are very sick and would fail the preoperative screenings who can still be salvaged. This is a picture of Philadelphia. Downtown Hahnemann Hospital and Drexel is over in this part. We have a beautiful parkway with an art museum here. City Hall is here, and these are brand new office buildings, and commerce in Philadelphia seems to be booming. Dr. Lee talked to us about all of the pre-op evaluations, and aortic valve and mitral valve, tricuspid valve, and we also talked about intracardiac shunts. Right ventricular function is really the main reason to evaluate patients. It's the leading cause of mortality afterwards is right ventricular dysfunction. In addition to right ventricular function, renal function and hepatic function is also very important. So renal failure would be a contraindication to LVADs. Renal insufficiency is a major risk. Some patients who have renal insufficiency can be supported with temporary mechanical support to see if we can turn the renal function around. Hepatic function often is a marker of liver dysfunction, which is right heart dysfunction. So hepatic function needs to be worked up very, very carefully as well. This is the major tourist spot in Philadelphia. It's Independence Hall. It's where the Declaration of Independence was signed back in the mid-1700s, which for us is exceedingly old. Well, let's go now to mechanical support. And this was not talked about in any of the other talks, so it will be novel. There are various modalities that we have available for us for temporary mechanical support before putting in durable mechanical support. There's an intra-aortic balloon pump, there's Impella, there's the tandem heart, and there's ECMO. They also are right ventricular support devices, but I'm going to talk most about left ventricular support devices. Those four devices, balloon pump, Impella, tandem heart, and ECMO, do have slightly different benefits and disadvantages. Balloon pumps can reduce afterload, and so can the Impella, as opposed to tandem heart and ECMO. Cardiac flow is minimally increased with balloon pumps, more so with Impella, tandem heart, and ECMO. But balloon pumps are smaller. The risks of bleeding with those devices are lower. Myocardial oxygen demand is reduced with a balloon pump, coronary perfusion increased. Impella, more so, maintains coronary perfusion, reduces oxygen demand. Tandem heart and ECMO don't really increase cardiac perfusion and don't really increase or decrease myocardial oxygen demand. This is a patient that I presented several months ago at one of our monthly joint Drexel Sejong International Satellite Cardiovascular Conferences. 64-year-old man with severe dilated cardiomyopathy on milrinone, class 1B, admitted again with acute decompensated heart failure. The milrinone was increased. He was dying without anything else. We placed an Impella increased him to a 1A, and we did increase his cardiac index. The milrinone was lowered, and he actually was a temporary bridge to transplant, but it also could be a bridge to durable VADS. This is a paper looking at balloon pumps or looking at Impella devices as a bridge to cardiac transplant. This study had the Impella 5. There were 40 patients from Baylor University, all had Impella. 20 of them had a bridge to transplant, 20 had a bridge to durable cardiovascular support. Their age were similar to our patient, age 50 to 60, 78% were men, about almost 50% had cardiac disease versus non-ischemic cardiomyopathy. Valvular disease, about 25%, 70% arrhythmia, renal dysfunction, 70%, liver dysfunction, about 20%. These were sick patients. 25% or so had prior PCI, cardiogenic shock, 45%, ischemic cardiomyopathies, 50 to 60%. New York Heart Association class 4, almost in all of those patients. The Impella device was able to improve their hemodynamics. Pre-Impella, the blood pressure to post-Impella increased. Diastolic blood pressure increased a little bit. The mean arterial blood pressure increased. Cardiac index improved from 1.8 to 2.8. Cardiac output increased. Cardiac power also increased, which is a marker of cardiac function as well. So the Impella in the 40 patients, 20 were a bridge to heart transplant, 20 a bridge to LVADS. 75% with the Impella survived to the next therapy. And if they survived to the next therapy, almost 90% survived to their final therapy, which was transplant versus a durable device and discharge. So Impella can support the patients as an effective bridge to decision strategy. Hemodynamically, patients were stabilized, and these were critically ill patients. The majority of the patients could be further bridged to the next therapy with favorable outcomes. So the use of temporary cardiovascular support can be used before durable cardiovascular support. We're nearing the finish. What about another kind of temporary device? What about balloon pumps? This is a trial using balloon pump in patients prior to durable support. In this study, there were 390 LVADs. Before the LVADs were put in, 56 had balloon pumps. 31 of the patients with the balloon pump stabilized, and 23% decompensated. Here are the patients that stabilized versus those that decompensated. More patients were ventilated the patients who stabilized had less ventilation than those that decompensated, and those that stabilized had less time in the ICU than those who didn't. The marker of those that stabilized versus those that decompensated was in the determination of right ventricular cardiac power. So if the right ventricular cardiac power was greater than 0.13, they had a much higher chance of stabilizing on the balloon pump. And if the left ventricular cardiac power was greater than 0.33, they also had a greater chance of stabilizing than if they didn't. So in conclusions, half of patients with chronic heart failure developing acute cardiogenic shock will stabilize with an intra-aortic balloon pump, and baseline measures of right and left ventricular cardiac power may predict which patients are likely to stabilize with an intra-aortic balloon pump. The third kind of device that can be helpful to stabilize patients for durable support is the ECMO device. And this is a study from the University of Michigan, extracorporeal life supports with left ventricular assist device bridge to heart transplant. These are the patients. They were very sick. The mean age was young, 45 to 50. Ischemic cardiomyopathy was 70% in the sickest patients, 40% in the not sick patients. Patients were intubated. They had renal insufficiency, hepatic dysfunction. The INR was elevated as well. ECMO in the very sick patients could stabilize the patients to be about the same as those who are less sick, and then they would both have a 70% chance of being stabilized onto their durable cardiovascular support. So this study showed that an initial strategy of resuscitation with ECMO can be effective in patients with extreme hemodynamic instability and multi-organ injury. The rate of LVAD survival post-ECMO support was not different for the different rate of LVAD alone in less critically sick patients, but the strategy of reducing the use of LVAD resources by avoiding LVAD implants in patients who would not stabilize with ECMO may be a good way of determining which patients should get that kind of device. The last study I wanted to share with you this afternoon is a composite of multiple types of temporary support from multiple medical centers. This one comes from the Fairfax Hospital, ANOVA, which is just outside of Washington, D.C., University of Michigan, Vanderbilt, Mayo Clinic, and St. Vincent's in Indiana. And in this study, they looked retrospectively at all the patients that had temporary support prior to undergoing durable cardiovascular support. 32% of the patients had ECMO, 43% had a tandem heart placed, about 20% had Impella, 6% had Centromag. In these patients, RVAD was needed in about 20% of the patients. Post-op hemodialysis, 25 to 30% of the patients. The patients were all admitted for about a month. And the final results, alive on support was 40%, transplant about 30%, and death in about 30% of patients as well. Bleeding risk was significant, stroke risk was low, there were infections and device thromboses. But temporary support was pretty comparable to the sickest patients in profile 1, worse than the less sick patients in profile 2 or 3. So again, the use of temporary cardiovascular support in critically ill patients with cardiogenic shock can restore hemodynamic stability and reverse end-organ damage, and the residual risk of short and long-term events remains high despite the use of temporary support. Well, I'm sliding on home just like our Philadelphia Phillies are doing, and I'd like to thank you very much for your attention. Hopefully I picked up a little time so we could all get our coffee break as well. Thank you very much.